Good evening, everyone. Welcome back. Or for those of you just joining us, my name is Dr. Devin Singh.
And I'm Dr. Alex Kabiri, and now we're going to review some of the landmark glaucoma studies that have helped to shape our understanding and management of glaucoma today.
We apologize, some of the doctors from our previous talk had asked a few questions regarding the amblyopia lecture. We'll get back to it at the end of this talk if you stick around. So in the mid to late 90s, a series of studies, well also the 80s as well, a series of glaucoma studies were done that really shaped the landscape for how we treat glaucoma today. We're going to go over each study individually, and also we're going to question you all and also give our own feedback to how we feel these treatment strategies have changed over time, because our glaucoma treatment options have changed since these studies were first made. Back in the 80s, we didn't have prostaglandins. We didn't have combination drops such as brimonidine mixed with timolol or desolamide mixed with timolol. We didn't have desolamide at one point. For a lot of older docs that were practicing in the late 80s, early 90s, their choices were pilocarpine, timolol, or systemic carbonic anhydrase inhibitors. And so we're going to keep that in mind when we talk about the results from these studies.
And some of those things we do still have, like pilocarpine, but they've fallen a little bit out of maybe out of favor, out of use, but they're still there as valid options.
And also for formality, we have no financial disclosures.
So this, if you saw the title slide, it showed that there was somewhat of a constricted field of vision looking at the faces of two young children. And that's one of the important things to keep in mind, is that whether we're looking at the glaucoma studies or our own glaucoma management, the primary endpoint is always around preserving vision, or looking at loss of vision, or a reduction in loss of vision in one arm of the study versus the other arm of the study. So the visual field test and trying to get a reliable, repeatable field is very important. On some patients, you can't get it, fine, but for the most part, try.
Right, we're going to talk a little bit more later on also, the importance of repeating visual fields, and also the efficacy of OCTs and how they've also changed glaucoma management, because OCTs weren't around when these studies were first done. The goals of this course, first we're going to review a series of the glaucoma studies, and they show, how we evaluate when to treat ocular hypertension. What is the efficacy in lowering IOP in glaucoma, and we're also going to compare topical therapy versus surgical management. We're going to go over some of the risk factors in glaucoma and ocular hypertension. We're also going to review some of the what we're suggesting as shortcomings and limitations of these studies, and we're going to ask you all to provide your own opinions also in this regard. And also we're going to review some glaucoma cases and try to apply some of these study lessons.
So the studies that we're going to review, while they are key and very influential studies that help to shape our understanding in the management of glaucoma, it is not an all-inclusive list. Some of you may be familiar with other studies that we don't mention, and please feel free to mention them.
Right, a lot of these studies, a lot of ancillary studies were done thereafter, or subsequent studies were done based on the findings of these studies, or also looked at some of the long-term changes of the patients involved, which we're not going to go into, but you're welcome to mention them in the chat, and we can all discuss it together.
Right. As with any good study, not only do you get the results of the study, but you also get a lot of good new directions to go in. So
right.
Sure.
First we want to stress the importance of understanding why we treat glaucoma, why we address it, why it's one of our big disorders that we look at in routine exams, and a lot of it is based on the prevalence of glaucoma. In the U.S., 3 million Americans have it, half of which are diagnosed. It's the second leading cause of blindness in the world after cataracts. In the U.S., more than 120,000 people a year are blind from glaucoma, and it accounts for 9 to 12% of all cases of blindness.
Now, blindness from glaucoma is 6 to 8 times more common in African Americans than Caucasians. So one of the things that we're going to look at as well is race as a risk factor. Glaucoma accounts for 10 million office visits per year. And according to the National Eye Institute, 1.5 million Americans with ocular hypertension and no glaucomatous damage are treated with ocular hypotensives. You know, one important thing to keep in mind here is this state of normal tension or low tension glaucoma. You know, many times patients are accustomed to having, we are in our practice are pretty accustomed to seeing, and in many instances being the first ones to tell a patient that they have low tension glaucoma. And a lot of these folks have been floating around, you know, for their every 2-year visits, optical visits, and presumably they've been told that the eye pressure was okay, and you know, therefore they were just kind of bounced on their way. But some of these folks do actually have what's called low tension glaucoma. So the thing to keep in mind, glaucoma is a disease state that is characterized by optic nerve damage, which results in vision loss. You know, the common metric that a lot of us look at of intraocular pressure is a risk factor, but intraocular pressure is itself not the disease. And it's not normal intraocular pressure or seemingly normal pressure does not exclude one automatically from having this disease.
Right, and us as clinicians, you know, we know that elevated intraocular pressure does not equal glaucoma, but unfortunately, a lot of patients get that impression. And so it's very important for us to distinguish the two. And the studies that we're going to be talking about in this course are going to be the Ocular Hypertensive Treatment Study, the Collaborative Initial Glaucoma Treatment Study, the Early Manifest Glaucoma Trials, the Collaborative Normal Tension Glaucoma Study, the Advanced Glaucoma Intervention Study, and lastly, the tube versus trabeculectomy study. With the Ocular Hypertension Treatment Study, the question this study tried to answer is when to treat or not to treat ocular hypertension. You know, we want to determine the efficacy and safety of using topical ocular hypotensitives in delaying or preventing the onset of open-angle glaucoma.
Now, presumably the value in a study like this is without having a line to draw that we could confidently say above a certain range of pressure you're very likely to have vision loss, so we can make a case for treating you to preserve the full field of vision that you have now. Without that, in some instances, clinicians would be left waiting for vision loss. The very thing that you're trying to avoid, you'd be waiting for it to happen before you're confident saying, yes, you need treatment.
Right, so, you know, we start off with talking about this study because this study helps set the bar for when or when not to treat elevated intraocular pressure. Because prior to the study, you know, the questions were, when does one treat ocular hypertension? Is it okay to delay treatment? Am I causing harm or vision loss? Or does even lowering pressure even efficacious in treating glaucoma? Does it even decrease someone's risk of glaucoma? And also, you know, how do we determine the level of risk of developing glaucoma? The conclusion of the Glaucoma Ocular Hypertension Treatment Study was that reducing IOP was in fact effective in delaying and preventing the onset of primary open-angle glaucoma in those with ocular hypertension. Now, not all patients with borderline or elevated IOP should receive medication, and hence why we're going to talk about determining level of risk.
Definitely, and this is where your optic nerve OCT is so useful. This is where being able to look for notching of around the cup, being able to look for a family history, retinal nerve fiber layer wedge defects with matching visual field defects. For some of these folks, you know, if you're not sure or the 24-2 is clean, but you think you see within that central area a retinal nerve fiber layer wedge defect, or maybe a disc hemorrhage, you know, which is a huge marker, a hugely significant marker, not size-wise huge, but huge marker of huge significance. Maybe it makes sense to bring some of these folks back and do a 10-2 visual field and try and see if you can find some matching structural and early functional loss.
And also, as we're on the topic of the ocular hypertension treatment study, before we go into the results, a question I want to pose to the audience that are watching. Let's say we label ocular hypertension as having an IOP of 22 or greater. Having the docs listening in would say that they would prescribe ocular hypertensive across the board for patients with ocular hypertension. Meaning if you have a patient with elevated IOP, your initial instinct is to treat. How many of those listening would agree with that statement? Right, and we see that across the board, none of us would likely treat right away. But now think about if you were practicing before the study was made. You know, I'm sure there would be more disagreement there.
So let me ask you, what variables might impact your decision to pull the trigger a little bit earlier?
And one factor one of the doctors alluded to is if the intraocular pressure is significantly elevated, you know, in the upper 20s. We know that corneal thickness does play a role in the risk factor for glaucoma, and that's largely based on this study. That one of the messages that this study left us with is that we need to determine a patient's level of risk, whether they're high risk of conversion or low risk. We know that race does play a factor too. And also we should consider a period of observation. One of the findings from the ocular hypertension treatment trials was that patients with thinner than average corneas are at a greater risk of converting to open-angle glaucoma, particularly if their intraocular pressures were on the higher side, meaning the upper 20s, as opposed to the lower 20s. You know, but there's still some debate whether having a thin cornea is a causative factor or if it's simply impacting our intraocular pressure measurements. Because, you know, a thinner cornea is going to result in a lower than actual measured intraocular pressure, depending if you're doing tonometry or in CT.
And that's another thing that we keep. You know, we have the amblyogenic criteria, you know, tucked away in each exam room, and we also have a conversion chart that's easy to refer to for corrected IOPs. You know, if, for example, somebody who has a corneal thickness of, let's say, for example, 505, we might add +3 to whatever IOP we find, whereas somebody who has a corneal thickness of 585 microns, we might subtract 3 from whatever IOP we measure.
Right, and a lot of docs some will actually do that addition or subtraction, and some will use it more as a guideline for whether they treat or not. And a lot of the responses we're getting from our viewers, and we appreciate it, you know, they're alluding to all the things that we're going to talk a little bit about later. We're going to look at corneal pachymetry, family history, if they have any chronic diseases such as diabetes. And a lot of this feedback is great and wonderful, and a lot of it is because of the lessons we learned from these initial studies done before.
So one question on ocular hypertension. You know, I had a young patient who had very, very significant optic disc drusen. Very significant. She had a cup of maybe 0.1. She had some spotty visual field changes, and her corrected intraocular pressure was 23, you know, plus. So 23, I think on one visit it was 24, but it was never lower than 23. She's somebody that I followed for a while, and ultimately thought that it was better, since she does have visual field changes already, to treat the ocular hypertension to avoid further loss or compromise of her visual field.
Right, that's a very difficult case too, because, you know, here we know with optic nerve head drusen, they can induce visual field defects that can mimic glaucoma. And as a clinician, it's very difficult to distinguish between glaucomatous defect versus that due to optic nerve head drusen. And with considering the patient is very young, you're concerned about their long-term visual outcome. And you're weighing that versus the side effects of topical treatment. I mean, fortunately, with modern topical treatment, these side effects, relatively speaking, are mild and treatable. So you bring up a good point on what pulling the trigger in this particular situation. If you all have similar examples of where the decision to treat versus not to treat was difficult, please share them with us. But yes, the take-home message with this study is that we're not treating all our ocular hypertensive patients, that we have to assess their level of risk of converting to glaucoma. And we know corneal pachymetry and race and systemic disease does play a role in their risk of progression to glaucoma. And right, one of our doctors is bringing up a good point too. If you don't see glaucomatous cupping or neurofibrillary loss, then it's not true glaucoma. Now, the next study we're talking about is the Collaborative Initial Glaucoma Treatment Study. And the objective of the study was to determine, patients with newly diagnosed open-angle glaucoma, whether it was primary, pigmentary, or pseudoexfoliative, whether it was better to treat with medication or immediately aim towards surgical management. In this case, they used trabeculectomies in this study.
So the study also examined the effects of medical versus surgical treatment, specifically trabeculectomy, on quality of life.
The study,
large study, 607 subjects, and what was found was that there were no significant differences in visual field loss. Again, the primary endpoint being that of a visual endpoint, visual field loss between the medically treated group versus the surgically treated patients. However, patients assigned to the TRAB group had slightly lower IOPs and a greater rate of cataract progression.
And that's an important thing to consider also, is that you want to warn your patients that, after trabeculectomies, there is a risk of cataract progression or hence of loss in visual acuity, which patients oftentimes will notice a loss in acuity before they notice a loss in their visual field.
Now, just as a safety, as a side note, some of these studies usually have, in case in one study arm some patients fail, what's the rescue treatment or the rescue med. In the surgery group, patients assigned for immediate filtration surgery underwent trabeculectomy, but if it failed, they then got ALT and medications. And the medication group, while they started out with a one-drug regimen, if that was not sufficient, additional medications were added. And if the pressure remained high despite using multiple medications, or if visual field loss was observed, then the patient would get ALT prior to possibly having a subsequent trabeculectomy.
Right.
And the difference between in IOP from the trabeculectomy group versus the medication group, we said it was a bit lower, but it was on average 2 to 3 points lower.
So the question then becomes, when do we suggest surgery in our newly diagnosed or mild glaucoma patients? When discussing surgery with patients, you want to review the pros and cons of surgery. We want to know, is there a difference between starting with medical treatment or surgical treatment with different degrees of glaucoma?
I think it depends on the surgical treatment in question. Mm-hmm. As we're going to see in some of the later studies that we're going to look at, a case could be made for laser procedures as first line, but no strong case was made for going all the way to a trabeculectomy as first line treatment in newly diagnosed patients.
It sort of highlights that point we were making before, that our management strategy has changed since these studies came out, because at that time things such as SLT were not available, or prostaglandins or combination drops when comparing medical treatment to surgical treatment. In the SIGIT study, they attempted to answer this question by comparing topical treatment to early surgery. And us as clinicians, our only controllable risk factor for glaucoma is IOP. And luckily, in both treatment arms, there was almost equal success in lowering IOP. Though one downside with the surgery group is the need for a subsequent cataract surgery down the line. After 4 years, patients in both groups had similar acuity and similar visual fields, and few patients developed serious vision loss from glaucoma after either treatment. So then it becomes, comparing quality of life. You have to think when patients undergoing trabeculectomy, they have to deal with the consequences of surgery and also the risk of decreased visual acuity because of cataract progression after treatment.
And keep in mind, this does not take away from the value of trabeculectomy for more moderate to more advanced glaucoma cases. These were newly diagnosed cases in this study.
And also, you may ask, okay, so if patients can expect similar outcomes, I want to lean more towards medical therapy because of the lower risk of affecting quality of life. When does doing surgery first become advisable? So in the longer-term follow-ups in the study, they found that significant visual field progression was found in both groups. Patients with mild field loss at baseline did equally well with either forms of therapy. However, those with more advanced field loss, they benefited more from having an initial trabeculectomy. The exceptions were your diabetic patients and African Americans. So the study does support doing early surgical intervention in patients with more advanced glaucoma, with the possible exception of your diabetics and your African Americans. And again, the important thing to think about here is, when we're comparing medical treatment to surgical treatment, the medications have changed and so have the surgeries.
Absolutely.
So although this study serves as a guideline, it's not a hard and fast rule. So some of the shortcomings of this study were that, there were slightly more males and females enrolled. A substantial percentage of them were African American. Most of the enrollees, the vast majority were primary open-angle glaucoma as opposed to pseudoexfoliation and pigmentary. I would be curious to know, whether that played a role in the outcomes. In those patients, although pigmentary and pseudoexfoliation is less common, do these numbers stand up for them as well? So the take-home message for clinicians with this study is that when you're discussing these options with your patients, you have to explain the relative risk of blindness to not only reinforce compliance, but you also want to put patients at ease and to lower their risk of depression, because they did find that the risk of depression was fairly high when diagnosing glaucoma, because when a lot of patients, when they hear the word glaucoma, they're thinking, and rightfully so, they're thinking blindness. So, it's helped to stress the slow progression of the disease, and that with either form of treatment, the outcome is fairly similar. And you want to consider surgery first in your moderate or advanced glaucoma patients, with the exception of possibly if they're diabetic or African American. You want to say that, okay, their risk of success is a little bit lower with surgery. Filtering surgery is more easily done before drops are used. And the study found that average IOP was more important than the variations, and major surgical complications were rare. The question posed in the study was that, are there socioeconomic factors, smoking, or other things that may play a role in their IOP control? Through the first 9 years of follow-up, the surgically treated subjects, demonstrated consistently lower IOPs compared to those under the medical arm. We also found that smoking, lower education, and worse baseline visual fields were associated with higher IOPs after surgery.
Yeah, interestingly enough, after trabeculectomy, patients who were smokers had higher IOPs. Very interesting.
Hence why, when you're managing your glaucoma patients, it sort of emphasizes the importance of the social history. A question I like to propose to the doctors listening is, what are your impressions when you're discussing surgery versus topical therapy? When you first encounter your patients, usually in your first few visits, at what point do you start to discuss surgery versus medication as your options? And do you consider a patient's social history in your decision making?
So one of our docs is mentioning that one school of thought suggests that more variation in diurnal IOP is more of an indicator for progression and more poor prognosis versus higher mean IOP. So again, this is what this study suggested. This study suggested that a higher mean IOP was a worse prognosticator than more variable IOPs.
Yeah, definitely in the case of normal tension glaucoma, there is some research looking at diurnal IOPs and whether systemic hypotension in the evenings play a role in normal tension glaucoma pathology.
I mean, we can go a step further and say, then let's look at, the diurnal of the systemic blood pressure, as well as some of the diurnal curves of blood pressure with patients on different, systemic blood pressure medications, and then see how those in turn might affect ocular perfusion pressure, and see if perhaps there should be a discussion between the eye care provider and the patient and the physician that manages their blood pressure about maybe switching blood pressure medications to one that might allow for a more favorable ocular perfusion pressure during the night. Right, so there are more things to consider, certainly, and any good study like this one certainly points fingers in different directions to look at. So
right, and that's a good example of how our management strategies evolve over time. And as we all alluded to earlier, we're going to look at how systemic disease does play a factor in certain forms of glaucoma.
So, comparing surgery versus drug therapy with the patient. In this study, an aggressive target IOP was established, and patients will ask. Oftentimes when we go to prescribe a medication, if they may ask, "Is this a forever treatment for me?" And we might say, "Well, it's a forever problem that needs long-term follow-up and long-term management of some sort, whether it's medication or surgery or some combination thereof." We're starting with medication, but some will ask, well, which is more effective for me? Should we just go ahead and try some procedure and see if I can avoid the medication altogether? It's a nice question. Which is more effective for preventing permanent vision loss? In other words, preserving their field of vision and their acuity. We think of peripheral vision. We think of doing a visual field. What consideration do we give to visual acuity? And how the therapy that we prescribe might impact their quality of life. And what's the patient's perspective on their risk of vision loss? Do they take it seriously? Or do they feel like, well, if I feel okay, I'm probably okay?
So the question I want to propose to the doctors listening, how do you address these patient concerns in the exam room? What do you think is the patient's perspective on associating their visual acuity with their glaucoma? What are your patients' perspective on their quality of life when they're weighing using drops versus the prospect of doing surgery? Or if they've already had surgery, what's their opinion on going back to drops?
I think one challenge in a newly diagnosed glaucoma patient, or even somebody who believes that they're being compliant and has had historically stable results, I think one thing that's challenging is, how do we take that person who feels okay and believes that they're okay and convince them that even though they feel pretty good and they see normally at this point, that they have a problem that needs some sort of intervention? One of our docs is suggesting that, in their experience, most patients are not interested in surgery for glaucoma. And that is the case for many folks, you know, but we've also had folks who have known people who've had laser treatments, whether it was laser PIs to help them lower their risk of narrow or closed-angle glaucoma, or SLT to help reduce their dependence on drops. You know, they know people have had some of these procedures done, and they'll ask, you know, is there anything I can do? Because I saw my friend or coworker had some procedure done that was relatively well tolerated. They didn't seem to miss a beat from their normal life, and I'd like to give it a try.
Right. I agree with a lot of the doctors in the chat that are, you know, saying that a lot of their patients aren't really interested in trabeculectomy surgery per se, but I think they're more open-minded to SLT or ALT because it's less invasive.
Sure.
The study did highlight that, you know, aggressive IOP does yield results in slowing the progression of glaucoma. So one question that can answer there is, you know, can the IOP ever get too low, or can we ever be too aggressive with managing glaucoma? From the standpoint of preventing progression, I don't think so. I mean, when you are using drops, though, you may want to have to deal with the side effects of using multiple drops, which is a different story, which we'll get into a little bit later. But, you know, we also want to say, you know, quality of life, you know, plays a huge role, and one of the benefits of this study is that it highlighted that aspect. You know, one of our docs brings up a good point that they gauge their patients' motivation with treatment, either medically or surgically, in order to see what's their likelihood of compliance.
Sure, we do have patients who while they're getting good results with topical therapy, they're actually feeling the cost burden of the ongoing therapy. Sure. Right,
when they weigh the cost of, you know, expensive brand name medication that's working for them, less side effects, but they can afford treatment versus a covered surgical therapy.
Yeah, there's a simple in-office procedure which actually might allow them to lower that ongoing monthly expense somewhat. But as Doc was mentioning, it is very important to try and gauge who's sitting in your chair and talk to them in the way that they'll hear. Right. You know, have advents in surgery or in topical treatment today altered the scale? Things like such as SLT, which is done right in the office, tube shunts or valves, certainly the advent of the prostaglandins and the prostamides like, latanoprost and travoprost and Lumigan. Does mitomycin-C have a role? I mean, there are so many nice advents that can help people get better outcomes with minimal intolerance.
Yeah, with mitomycin-C and 5-uracil, fluorouracil, it's aided in the success of trabeculectomies. You know, both these agents are, you know, anti-fibrolytics.
So less scarring and better filtration.
You know, so these are, you know, some of the examples of which, you know, advents in treatment have tipped the scale when examining these historic studies. And then, you know, the next study we're going to be talking about is the early manifest glaucoma trial. And the purpose of the study was to determine the effectiveness in lowering IOP in early glaucoma in patients who had untreated open-angle glaucoma. Its secondary aim was to explore the natural history of glaucoma in its untreated state.
So looking at the effect of immediate treatment versus no treatment or later treatment, patients were followed for a minimum of 4 years, and they were seen roughly every 3 months. The patients were aged 50 to 80 years old, and they were randomized into treatment groups of betaxolol with ALT or no initial treatment. In the treated group, if the pressure was still greater than 25, they also got Xalatan. And in the untreated group, if the pressure was greater than 35, they got Xalatan. And then if it was still high, then individualized treatment regimens were explored. The study outcome, the primary endpoint, was based upon visual field analysis and disc photographs looking for functional and structural changes. And what it showed was a considerable benefit of treatment, of early treatment in delaying the progression of glaucoma.
Whereas the previous study was looking at which is a better initial treatment, this study questioned whether initial treatment was even necessary. And the study did support the idea that yes, treating right away was the best approach to take to preserve patient's vision without causing any glaucomatous damage. Prior to the study, it wasn't well defined, the natural history of glaucoma. Clinicians didn't know how rapidly glaucoma would progress if it were left untreated. And because it was unknown the rate of progression, it was difficult to gauge the effectiveness of treatment in a glaucoma.
And if we look at the measurements of pressure, where they drew lines at 25, they drew lines at 35 as well, these can give us an idea, a ballpark idea of where some of the lines are in terms of risk of progression of glaucoma.
And as a safety in the control group, patients were followed as long as there was no progression, and if they did develop progression, then they were then treated, thus not exposing them to unnecessary vision loss. After 6 years, patients in the control group took 4 years before detecting any advances in glaucoma. In the treatment group, it took 5.5 years to detect similar changes. And on average, their IOP was about 25% less. So if you are choosing to observe your patients with questionable glaucoma, at least this study highlights that progression can be very slow. And you can also stress to your patients that treating does slow the rate of progression if progression is to occur anyway.
Yeah.
Some of the shortcomings of this study, it was a particularly small group. 66% of them were women, so there is some gender bias there. The study was limited to the ages of 50 to 80, and the subjects were taken from a very small part of the world. So we really don't have a whole wide racial demographic here to look at.
And the medications used, betaxolol being being a selective beta blocker, I think a lot of us are more writing timolol than betaxolol, so that's one potential difference. And also latanoprost or Zalatan being a prostaglandin analog versus something like, for example, Lumigan, which is a prostamide. And while there are some similarities in terms of the proposed mechanisms of action and the observable effect, there are also differences in terms of how the drug enters the eye, time to peak concentration in the anterior chamber, drug availability in the anterior chamber. So it might have been nice to tease out some of these differences as well.
Right. And as you had mentioned before, if patients were showing inadequate response to betaxolol, then they were then given Zalatan, and they were moved around in the studies. This study doesn't really give you a true natural history as the disease changes. It doesn't tell us whether glaucoma progresses slowly entirely, or is it more like a snowball, where it advances more rapidly over time. So some of the lessons we learned from this study is you want to follow patients very closely to look for progression. Your target IOP may change over time, as it did in this study.
Absolutely, and it's certainly as glaucoma progresses and things become a little bit more delicate and preserving vision is a little bit more urgent, if they have some visual field loss already, then the target IOP goes lower. And certainly every millimeter counts. I hear people sometimes say, listen, one point's not going to make or break my management plan. Okay, there is a little amount of fluctuation in terms of IOP, which you try to minimize with your management plan. The amount of diurnal fluctuation, you try and keep it as stable as possible, but certainly every millimeter is significant. You feel better if you see a pressure of 16 versus a pressure of 17, right?
Right, or if you have patients with an IOP of 11 or 12 in the office, we had mentioned before diurnal fluctuation, you don't know what their pressure is outside the office if it's a little bit higher, so it doesn't rule out the possibility of adding more drops to get that extra millimeter or two reduction.
Absolutely.
Because in the average and the long term, in the diurnal curve, it may effectively lower the pressure overall.
And that's why, again, the primary endpoint not being one of pressure, but the primary endpoint being one of preserving vision is so important. Looking at that visual field over time, looking for any changes and thinking, you know what, this is a patient who's got, pressures of 14 or 12 every time I see them, but I'm noticing some subtle changes,
Right. If you do see definitive progression in the visual field, then you have to change your management strategy, even if it means aiming for a 1 or 2 millimeter reduction in IOP.
So how does this study impact our treatment today? Well, certainly one thing we want to distinguish is progressive versus a non-progressive disease state. And the rate and type of progression was highly variable in the untreated or delayed treatment normal tension glaucoma group. Non-progressive NTG does exist, certainly does exist, and it may warrant observation without treatment, albeit maybe more frequent and a bit more careful observation.
Right.
Doing things like alternating a 24-2 visual field with a 10-2 visual field, maybe doing a macular OCT for the purpose of looking at the ganglion cell layer, things like that, taking a careful look and looking for disc hemorrhages, very important as well. We might bring patients in, do a visual field, do an optic nerve OCT, and not pick up that 78 or 90 lens and look at the nerve. But we could be missing a chance to notice a disc hemorrhage. Certainly very, very important. I can tell you that disc hemorrhage for me is a very significant finding. What it means, disc hemorrhage means that there's an active disease, active and progressive disease going on. In terms of glaucomatous patients versus, normal patients, not all glaucomatous patients show disc hemorrhages, but in terms of normal non-glaucomatous patients, 0.1% to 0.2% of normal people may show disc hemorrhages. Why? Well, sometimes you can have a disc hemorrhage due to a posterior vitreous detachment, but it's certainly a sign of damage, and it does take about 4 months to clear. In terms of why they form, well, there are two main theories that have been kicked around. One is you can say is the vascular theory, and the other being a mechanical theory. The vascular theory is that the vessel breaks first, which then leads to a loss of blood supply locally, leading to damage and therefore progression. This is maybe possible in people who are susceptible to vessels breaking, or they're just susceptible to glaucomatous damage more easily.
Such as your diabetic, right?
Yeah, sure thing. The mechanical theory is one that, some folks might think holds a bit more water, where the primary event is a neurodegeneration of the optic disc due to glaucoma, and then as the tissue is collapsing, this puts a strain on the local vessels, which then leads to bleeding. That's one that might hold a little bit more water. Disc hemorrhage, what do you do with it? Is it a finding that's significant enough to alter your management plan? For example, to push somebody over the fence from being a glaucoma suspect to being somebody who has glaucoma and needs treatment? Most folks would say yes. Is it something that can tell you in your current glaucoma patient that you're managing that the management is maybe needs to be reevaluated and a lower, more aggressive target IOP needs to be set? Yes, in both cases.
Yeah, I for one will pay particular attention to cupping in that region down the line, or notching, or field loss that correlates with that region of the optic nerve.
Now, I'll tell you one thing that I do sometimes. If somebody has, if they have a cataract, this doesn't work. But if they have an IOL implant, that's clear, or if they have a relatively clear natural lens, let's say grade 1 plus nuclear sclerosis or less, I'll turn the slit lamp, the light up right, I'll put the blue filter, the cobalt blue filter, and then I'll hold my 78 or 90 lens and look at the nerve.
For like a wedge defect?
For a wedge defect, it'll jump right out at you. Yeah.
If you all have any thoughts with regards to assessing disc hemorrhages and how it affects your glaucoma management strategy, please share with us.
One of the docs is saying, do I mean red-free? I know what you're saying, but try it both ways and you'll see. You can observe it both ways, but it can jump out at you more if with the blue. Try. If you haven't tried, try.
Now, with the collaborative normal tension glaucoma study, one of the questions it designed to ask is, does lower IOP work effectively in normal tension glaucoma? Although it sounds straightforward to us today, of course we treat IOP normal tension glaucoma. At the time of the study, it was debatable. Clinicians were questioning whether there was a different mechanism behind normal tension glaucoma other than its effect on elevated IOP. And the studies show that it's worthwhile to lower pressure, but you have to be more aggressive. There was a slower rate of field loss in cases with a 30% IOP reduction or more. The rate of progression was more variable without treatment, and half of the non-treated group did not progress for 5 years without treatment. Some of the risk factors in normal tension glaucoma progression were gender, migraine sufferers, disc hemorrhages, as we just mentioned, and also cardiovascular disease, such as diabetes, hypertension.
So looking at the inclusion criteria, 260 subjects with normal tension glaucoma, which was either progressive or had visual field defects affecting central vision. Subjects in the treatment arm received topical pilocarpine, systemic carbonic anhydrase inhibitors, laser, trabeculectomy, or a combination of treatments to attain a 30% reduction in IOP. And both groups were followed for up to 5 years. The natural history of normal tension glaucoma, sometimes, it does not progress, and surgery may not be necessary. The study goal was a 30% reduction in IOP by one or more of the aforementioned methods of reducing IOP, and 50% of the treatment group was able to attain this using only medicinal therapy, which in the study was pilocarpine and systemic CAIs. We can expect less normal tension glaucoma patients to require surgery today with modern drops. One of the first line for many normal tension glaucoma patients nowadays is prostaglandin.
Prostaglandin, right? And with most prostaglandins, you'll expect about 30% IOP reduction with a once at bedtime treatment alone. And then on top of that, if you add your combination treatments of your beta blockers and your brimonidine or your topical CAIs, you may not ever need to consider surgery in these patients. Another point to make here too is, when dealing with normal tension glaucoma, as the study found that there were many cases where they did not progress, so you want to follow these patients in the long term and carefully assess their visual fields for true progression. A question I want to pose to the doctors viewing is, do you follow a different approach in managing glaucoma in the case of normal tension glaucoma versus your typical primary open-angle glaucoma? How do you contrast your management strategies? So the question I was asking is, when you're managing patients with primary open-angle glaucoma due to elevated IOP versus managing your patients with normal tension glaucoma, how do your strategies differ in terms of the drops you're using, frequency of follow-up visits, your decision to change your therapy approach, whether it's how quickly you decide to change your medical treatment versus suggesting surgery?
Right, so one of our docs is saying that initially there's no real difference. The study supports that normal tension glaucoma patients don't really require surgery, so you can start off the same way. So if you're going to say prostaglandin or prostamide for first line, you could do that in either case and follow every 3 to 4 months. Sure, I think for the initial follow-up, maybe a bit closer to 1 month, just so you have a chance to see, are you getting an appropriate therapeutic benefit from the treatment, as well as give the patient a chance to complain about whatever they don't like about the medicine. It costs too much, their eyes get red, what have you. That way you have a better chance of keeping them on course, so they don't think they're having any abnormal side effect, and maybe they were misdiagnosed or mismanaged, and then they drop out of treatment and drop out of the practice, to nobody's benefit.
Right, and one other addition I would want to make to that is, as one of our doctors just mentioned, is when dealing with normal tension glaucoma, my target IOP is probably going to be lower than that of my mild open-angle glaucoma patient. Now, the next study we're looking at is the Advanced Glaucoma Intervention Study. And in this study, it looked at the long-term effectiveness of surgical treatment in your medically uncontrolled glaucoma patient. And this was based on their visual field and visual acuity loss, IOP complications, and time to treatment failure, and the need for additional medication.
Right, so they were evaluating the outcomes of different sequences of interventions that really involved trabeculectomy and ALT in eyes that had failed with medicinal treatment alone. The patient's range was 35 to 80 years of age. They had failed on maximal medicinal therapy, and these were all phakic eyes. And the arms of the study were either TRAB, ALT TRAB, meaning they had a trabeculectomy, which if it failed, they got ALT, which then, if that failed, they got a second TRAB, or they were ALT TRAB TRAB, meaning they got ALT, which then if it failed, they got TRAB, which if that failed, they then got another TRAB. And then if the eye failed the above sequences, they would have some individualized therapy, whether it was other procedures, maybe a tube, or other medicinal therapy mixed in. And again, the primary outcome of this study was looking at a decrease in vision, not only pressure, but primarily a decrease in vision. Secondary outcomes, again, sustained decrease of vision, failure of therapeutic approaches, and the number of prescribed glaucoma medications needed, as well as the level of intraocular pressure obtained with either approach.
Right, so the big difference between the two treatment groups is their initial treatment was either a trabeculectomy or it was ALT. Their second treatment was the opposite, and the final or third treatment was a repeat of the trabeculectomy. For the purpose of this talk, we'll abbreviate it with TAT or ATT. Advanced glaucoma was defined as visual field loss at the time of enrollment despite being on topical treatment. One of the findings of the study was that race seemed to affect outcomes. Caucasians did better when they had ALT first. African Americans appeared to do better when they had trabeculectomies first. Now, for both races, intraocular pressure was lower in the group starting with trabeculectomy. In terms of visual field or visual acuity, African Americans did better in the starting off with ALT.
So the recommendation, interpreting these findings, the recommendation could be made that black patients with advanced glaucoma start a therapy program with laser surgery, while whites without significant life-threatening health problems should begin with trabeculectomy. In other words, they're medically cleared for capable of being medically cleared for the procedure.
One thing to keep in mind too is, this study was patients were enrolled in between 1988 and 1992. Halfway in, 5-fluorouracil and mitomycin C were introduced into trabeculectomy surgery, which can affect the outcome and success.
Completely.
So, one of the questions, we as clinicians ask is, why did race matter in this study? In the study they found the disc hemorrhages were more prevalent among whites, yet blacks showed more severe glaucoma. Why? One proposed answer to this question is the subjects self-reported their race, whether it was white, black, Hispanic, or other. 57% of those self-reported as black, and overall this group was younger, and they had a greater prevalence of systemic disease. And they also had worse visual fields initially, although their visual acuity and intraocular pressures were comparable. The average age of the white subjects were higher, which could explain the greater likelihood of having disc hemorrhages, because we know disc hemorrhages are associated with cardiovascular disease and microvascular disease. They also found that the diabetic subjects, on average, had higher intraocular pressures, greater risk of cataracts, and interestingly, a 3-fold greater risk of failure of trabeculectomy, but not the case with ALT. The next question then becomes, so why did black subjects experience a higher failure rate with the arm starting off with trabeculectomies? Well, one suggested theory done by a subsequent study. If you're interested in looking at the study, it's listed below here. The study mentions that, remember, in this group, they were doing the trabeculectomy first, and then the subsequent trabeculectomy was done probably after the introduction of antifibrolytics. And the mitomycin C introduction and 5-uracil introduction later on may have contributed to why these subjects failed around their first round of trabeculectomy, because it wasn't used. Yeah. So who knows, perhaps if this study was repeated today, the results may be different. Going over the shortcomings, as I mentioned, the antifibrotics, such as mitomycin C, weren't available in the first half of the study. It's possible that newer glaucoma medications can affect surgical success. What about SLT? And also, do your diabetic patients need special consideration when considering surgical therapy? The question I want to propose to the doctors listening in is, when you're gauging the efficacy of, let's say you've already come to the decision that you want to have a surgical consultation for your patient because they're on maximum topical therapy. Do you factor in race or systemic disease when considering them for a consultation for laser therapy versus trabeculectomy? Or do you leave it up to the glaucoma specialist to make that decision?
I can tell you for myself, once we're failing with maximal medical therapy, I'm definitely sending them out for consideration for something,
Yeah.
And one thing that we've seen when we get some of these patients back, no matter what procedure they had, it makes a bit of a difference, like anything else. who did it, what was the technique, the experience level of the surgeon. They might not be able to see the person that you refer them to for insurance reasons or transportation issues, and they might do their own research or follow another recommendation from someone else, another provider, and find their way to somebody else.
Right.
And therefore, there are more variables thrown in there. So I tend not to make a recommendation as to the type of procedure I'm setting them for. I tend not to specify beyond that they're on maximal medicinal therapy, still showing signs of progression or compliance is an issue, what have you, and may benefit from some procedure.
That's a good point.
And then let them figure out the rest.
Correct, right. We'll consider, but it's a referral regardless. And we all agree that, if you're seeing progression with maximum topical therapy, then recommending a consultation for surgery is a must.
I think, and just to allow give them some more room to incorporate more topical therapy or change things around in case they develop an allergy to let's say, for example, brimonidine allergy is not uncommon for patients in this area. Maybe to keep one more medication free before they get to maxed out, progression, and send them for consideration for a procedure a little earlier. They might not come back having had a trabeculectomy done, or they might not come back having had a tube put in, but they might come back having had a successful laser that decreases their pressure a bit significantly to where they're not going to progress with their current medication regimen, and we still have one more in the works, or one more in the wind, woodwork if we need to give them one more medicine.
Right. Now, the last study that we're going to finish up on was the tube versus trabeculectomy study. And the question this study aimed to answer is, which glaucoma surgery is better? At the time of the study, tube shunts were reserved for high risk of progression glaucoma patients. And this study challenged the idea and questioned whether patients at lower risk would benefit from this surgery. And the TVT study did support the use of expanding the use of tube shunts. And that was based on the fact that the rate of vision loss or post-operative complications were similar in both groups. And the tube shunt had a longer success rate. The failure rate in the study for trabs were 10% per year versus 5% for that of tubes. And the take-home message here is, having tubes put in is a viable option. You have to consider the patient's unique needs. You have to think about the burden of topical therapy, the willingness to repeat glaucoma surgery, and of course, the skill set of the surgeon is very important too. And ultimately, the approach that's taken is dependent on the surgeon.
I think for us, from a medical legal standpoint, the thing is recognizing glaucoma in its various forms.
Yeah.
Doing appropriate testing, interpreting the findings accordingly, instituting appropriate management plans for the given stage of the disease presentation, and with the ultimate goal of preserving vision, making a time-appropriate referral when needed. That's really where we are, to make sure that we've done the right things and, not actively gone running down the wrong road. So that's good.
Right. Our role as primary care clinicians is to at least educate our patients that, these are their options. So that when you do send them for that referral, they're armed with the right questions to ask because they're aware of all their options.
So let me ask you guys a question. Many of us are equipped in the office to test and manage glaucoma that can be managed medicinally, to test for and monitor and manage it over time. But some of us may not be, or some of us, might work 1 day a week or 2 days a week in facilities that have, appropriate equipment to check eye pressure, and maybe a nice way to look at the back of the eye, look at the nerve, but maybe not to do visual fields and OCTs. And, in good conscience, we're going to refer those folks out for those tests. But what do we do with a patient who comes in with a pressure of, 42, 45 on day number 1?
Right.
That's that optical patient that comes in and, what do we do with that patient? Do we refer them straight out? Or do we refer them out with a prescription for medication to start getting their IOP lower, so that when they get to the refer to location, even if it's just to your other office, where you work, where you are better equipped, at least they're not running, they didn't come in with a pressure of 45 and walk out with it as well. They might not go to somebody else for 2 more years till their next optical voucher kicks in if it's not properly impressed upon them. So what do we do?
Now, some additional shortcomings we can, go over with, as a summary of all the studies we went over today. With the ocular hypertension treatment study, racial disparity. 25% were African American, the rest were Caucasian. It really didn't assess anyone that was under the age of 40. So we're left to, question, how does this impact our management plan for younger patients with ocular hypertension due to, for example, pigment dispersion? The SIGIT study went to 5 years, but what about the role of cataract progression after that point and its effect on, gauging vision loss, peripheral visual field loss, I should say? With the early manifest glaucoma trials, racial diversity was an issue. We were limited to a single group. But Taxol was the only medication used in that study as the initial treatment arm. With the advanced glaucoma intervention study, cataract surgery was done more often in the group after the first trabeculectomy. But how does that impact interpreting the study results? At this point, I want to leave it to those of you listening in. What are some other shortcomings you find with these studies that we've talked about, and how does it impact your management strategies today?
And one of our docs is mentioning that in the case of an optical patient in a facility that you're not appropriately equipped to manage glaucoma per se, but the pressure is unsafely high, let's say low to mid 40s, something like that. He's saying refer out ASAP with a big emphasis on urgency and risk. That's certainly one thing you can do. I think that we could go a step further. If this was in, let's say, our office, and I would have confidence to write a prostaglandin and say come back in a few days or a week's time to go ahead and check to see if the pressure's budging a little bit, or I might instill some drops in the office and see if it's starting to come down a little bit, have them wait half an hour. That's not a bad idea. I mean, if you implement a management plan that's working, and they come back to you in that same facility in a few days just to check the pressure while they have an appointment with Dr. X next week to go for a glaucoma workup and all that. If you started a management plan that's working and you see the pressure's coming down, and by the time they get to their refer to facility, the pressure is indeed coming down with no adverse effects, it's unlikely that Dr. X is going to, break something that's working. He's going to stick with the management plan and maybe add to it to get the pressure down a few more points if needed. I think we have a responsibility to start managing what we know to be dangerously high IOP, and maybe not just send out. Because remember, part of the way the patient got to that point, in this case of very chronically high IOP and chronic open-angle glaucoma, part of the way they got to that point is by not having treatment initiated and appropriate follow-ups implemented before. So it's one thing to communicate to them, but in our experience, sometimes when patients walk out without a prescription or a sample or some sort of medicinal management plan in place, what their impression is that, well, if Doc wasn't that concerned about it, if he was that concerned about it, he would have done something.
Right. Yeah. The last thing you want to do is be the last doctor that the patient saw and not receive any form of treatment or education.
That's the last thing you want to do. So you can pre-appoint them somewhere else, But to go one step further to protect yourself, you can write them, a prescription with no refill.
Right.
That'll cover them for the next couple of weeks while they're waiting to get to Dr. X, Because you never know what'll happen. They'll get a referral from they'll need a referral from their primary doc to go to that facility, and then they won't have it. The doc won't see them, they'll walk out, and they'll say, you know what, forget this, I feel okay, I'm probably okay.
Right. Also some of the new therapies and surgeries that are available that may change our management style. We mentioned SLT. We talked about how prostaglandins can help more effectively lower intraocular pressure and postpone or remove the need for surgical intervention. The same goes for our combination drops. We're learning more that blood perfusion to the optic nerve does play a role in glaucomatous damage. So we know cardiovascular disease and diabetes plays a role in glaucoma, particularly normal tension glaucoma. Having cataract surgery can help in the management plan as well.
As a space procedure, sure.
As a space procedure, right.
Sure.
Keep in mind when patients have had previous laser therapy because of, for example, diabetes or a branch vein occlusion, laser therapy can artificially create a visual field defect.
And every now and then we'll see patients who have these peripheral iris scars showing that they've had iridoplasty before, just to kind of mechanically pull that tissue out of the angle, sure. I can tell you that from my experience, gonioscopy is invaluable. It's maybe one of the most valuable in-office examination procedures that we can do. I know for myself, I do more gonio than most people I know, excluding Dr. Singh. He's right there with me. And it's hugely valuable. I think when we do a quick von Herrick assessment, we're really looking to see, is it safe to dilate this patient? Am I going to close the angle, acutely right now if I dilate this patient? And but taking a look around, 360 degrees of the angle and looking to see what's happening. Do they have some, peripheral anterior synechiae? That's very significant, to take a look for. Do they have a significant amount of pigmentation in the angle? These are things that, have they had a history in your uveitic patients who have recurrent uveitis or sometimes long bouts of what seems to be a chronic uveitis happening? Are they getting these kind of fibrotic deposits in the angle that can then form kind of these fibrinous membranes that can contract and start to pull the angle shut? You'll miss these things without doing gonio.
Right. In a later talk we're doing in the future, we'll talk more about uveitic glaucoma, narrow angle glaucoma, neovascular glaucoma. One of our docs brought up a good point with the corneal hysteresis. We're learning that corneal hysteresis does play a role in measuring accurately the intraocular pressure. And we also look forward to new technologies and studies in this area.
And once those studies are out, you're going to get them right here. Right here.
OCTs have changed dramatically, how we approach managing glaucoma. We're able to detect physical change much early on.
So one consideration in ocular hypertension is how much pressure can this eye withstand? And it's hard to draw a hard line and say this particular eye cannot stand more than 23 or 22 or 26 and a half. You can't really draw those hard lines. But we can say relatively high or relatively low, or this eye can withstand moderate ocular hypertension and this other eye maybe cannot. And one thing that we had touched on earlier was the case of very significant optic dysdrusen. There can be a case made for monitoring patients with significant optic dysdrusen, monitoring their intraocular pressure and visual field. Is it classical glaucoma? It's not. Of course it's not. But can they have, significant increases in visual field changes if the intraocular pressure is compressing that nerve fiber layer to where it's paper thin, and then they start showing dropouts in nerve fiber layer with drops in field that are hard to predict based upon the topography of the nerve head there with the buried dysdrusen.
Right. It'll be interesting in the future to see if we ever have large-scale studies like these that we've gone over that review some of the topics I have listed here. Large-scale studies looking at modern topical glaucoma medications. ocular hypertension and other racial diversities. Diurnal blood pressure and how its impact on glaucoma.
Yeah, diurnal blood pressure variations on different systemic antihypertensives, and how those in turn play a role in ocular perfusion pressure and normal tension glaucoma. Sure.
Further solidify the value of OCT in detecting progression and how it compares to just assessing the visual fields. More studies on pigmentary and pseudoexfoliation glaucoma history. Studying the natural progression of narrowing angles. And if you have any thoughts you want to share with us, you can feel free to add them. We're going to go over two case studies to sort of implement the lessons from the glaucoma study we just went over. If you're dealing with a 20-year-old young African-American male with intraocular pressures in the mid-20s, his acuity is 20/20 in both eyes. He's got average pachymetry, healthy cupping, but you do notice some carpet-inverted spangles. And he mentions his father has experienced vision loss, but he's unsure of why. How do you manage this patient? Right, gonio is very important to assess the angle. By and large, with pigmentary dispersion, you'll notice a very, very deep anterior chamber, which explains why the iris is chafing against these annuals. Unfortunately, with these patients, pigmentary glaucoma does actually improve over time, because as this patient approaches his 40s and 50s, his lens is going to expand and push his iris forward, which reduces the amount of pigment dispersion. But in the meantime, it's very important to monitor his visual field and cupping. You'll bring him back for a follow-up for a visual field, OCT. And we see how this case would be different if he had thinner pachymetry or more enlarged cupping.
Yeah, I think follow-up every 6 months would be appropriate. Looking for changes in the pressure, maybe on alternate visits. Doing a dilated exam, getting a good stereoscopic look at the nerve, and looking at the IOP, and then on alternate visits doing visual field, optic nerve OCT, and gonio.
In our second and last case, if you have a 45-year-old white female presenting with asymmetric IOP, glaucomatous cupping greater in the right eye, systemic history of controlled diabetes, pseudoexfoliation of the lens capsule, what additional information would you need? And how would it affect your management strategy? Well, I'm glad to see our viewers that appreciate the value of doing gonio.
Repeat and confirm that high IOP measurement. Sure, I mean, it might be more believable if you had a 0.5 CD in the right and a 0.6 in the left,
right.
But here you have it the other way around. So
right.
Definitely confirm that.
Yeah, one point to make here too, which is why I had the IOP in that manner, is with pseudoexfoliation you can have really variable IOP. So although it's normal on one visit, it can potentially be higher on the next. Good question. So let's say she is a high myope. How does that change your management strategy versus if she's hypertropic? I mean, definitely with a high myope, the myopia can contribute to the appearance of her optic nerves. At 0.6 in a hyperope, I'll be more suspicious versus a myope.
Sure. I think any of these folks who have diabetes, blood pressure, we want to take a look certainly at the back of the eye and see if they might have had a vaso-occlusive event. And depending on where it occurred, they might not know that they've had a vaso-occlusive event. If it occurred near, let's say, a bifurcation and the blood couldn't flow in one direction, it would just flow in another. It wouldn't just leak out and spill everywhere. So they could have a vaso-occlusive event with really no bleed. Or an ischemic event, with no bleed. So if that happens and they have an ischemic event with no bleed, they could get neovascularization, which undetected, unchecked, will just progress anteriorly, could grow to the iris and then into the angle. So one thing that I want to do, gonio is beautiful, but I want to take a nice look around the edge of the pupil under high magnification, good illumination, and look for tiny vessels that might be suggestive of neovascularization.
Good point.
So you don't see, think of a pressure of 26 the same way you think of of being neovascular glaucoma, right? You think of, pressures in the 60s, high 50s and 60s for neovascular glaucoma, but before they were pressures of 60, at some point they were 26.
Right.
So it's worth a look. Definitely worth a look.
We greatly appreciate the participation of you all throughout the course. One of the ways we learn is from each other in our own personal experiences. We're nearing the end of our talk. We'll stick around for another 5 minutes to answer any questions you have, or if you want to continue to share some cases you may have, we welcome it also. I want to remind you all that we all have a record of your attendance for the webinar. The last and final step is to look at the exams that are attached to these courses at MyODCE.com. You'll log in, you'll take the exam, and don't worry if you don't pass the first time around, you can take it again at no cost.
It'll tell you which questions you got wrong, so you know which points to brush up on, and then go back again.
Yeah. Once we have a record of your exam scores, we will then send the results to ARBO, so that you'll receive your credit. On the website, you will also find a copy of the PDF and this video for your reference.
And if there's any difficulty, if you run into any difficulty on the website, please email us at either myodce@gmail.com or ce@myodce.com, either way, and just let us know what the question is or what the difficulty is that you've run into.